everyone. This is David Bronstein with MCOL and Healthcare Web Summits, and I'd like to welcome you to our webinar event today, Coordinating Medicare Advantage Care, Aetna's Readmissions and Collaborative Initiatives. Our speaker today is Randall Krakauer, MD, National Medical Director for Medicare, Aetna. Before we begin, a few housekeeping items. If for any reason you experience technical difficulties with the web portion of today's presentation, you can follow along with the PDF version of the presentation. A link to this presentation was included in your dial-in instructions, and I will also give you the link to the PDF right now. And you can find that PDF, which is the exact same thing that's on the web, at http://www.healthwebsummit.com/Aetna, that's AETNA 031413. So that's healthwebsummit.com/Aetna 031413.pdf. And if you have any other questions or need assistance, need to get that link, you can also call the Health Web Summit office. And the number to call there is 209-577-4888. That's 209-577-4888. We'll be taking the any questions today with a chat feature. So go ahead and at any time during the presentation, you can type your questions in to the chat box and press send. Dr. Krakauer will be taking questions primarily at the end of his presentation, but you can ask questions at any time. With that, we're done with our introduction, and Dr. Krakauer?
Thank you very much. We'll be talking about some new features of care management specifically targeted at a Medicare population, which is basically an over 65 population primarily, but also a portion of it as under 65 with disabilities and end-stage renal disease. These are some of the new ideas that have been developed in the field, and some demonstration of impact or potential impact. We'll try and tie some of this together as best we can, because I think much of what we do is in fact synergistic. So let's start with the population that we're dealing with, and this is something that most of you on this call probably know, and this is what we call round up the usual suspects, or a list of conditions common in a Medicare population. The left bars represent prevalence, and the right bars represent the percentage of the total cost for that condition. And we have heart failure and chronic obstructive lung disease and diabetes, clinical conditions, dementia and dual eligible or psychosocial. We have decedents or advanced illness and institutionalized. So they're clinical. These are clinical conditions and psychosocial conditions. And all of them, these have several features in common. They're all prevalent. The costs are high out of proportion to their prevalence. And in all cases, there is opportunity to do better by better care management. The other is, if you add up the bars, particularly the right bars, they come to more than 100%, which brings us to the next important feature, and that is, in terms of chronic conditions in particular, we generally see multiple chronic conditions, not single chronic conditions in Medicare. In fact, more than 2/3 of the total cost in Medicare is generated by a population with more than 4 chronic comorbid conditions. A relatively small percentage, actually less than 5%, is generated by a population with a single chronic condition. This is important because these conditions interact with each other in a deleterious way. So the net burden is actually greater than the sum, as is the net burden on care management, because it is not terribly productive to engage and manage a single condition in isolation in this population. And in fact, care guidelines generated for a particular condition are frequently violated by a comorbid condition. So you really have to manage all the conditions, and for that matter, all the psychosocial barriers associated with them to be successful in Medicare. All right. There's several reasons why in a Medicare population an individual with a particular condition is different than a younger population or an employed commercial population. So everyone starts with the prevalence of high-risk conditions, which is true. Most of the conditions are much more prevalent in Medicare. And what we've already discussed, which is perhaps even more important than an individual case, is the greater incidence of comorbidities. We also see less identifiable symptoms for a particular condition, illness, or insult, greater potential for damage from an injury or condition, less tissue reserve, less reduced ability to recover from an injury or condition, less ability to follow a medical regimen, and less family and social support. All of these factors mean the same individual is different clinically over 65 than younger, than in an employed commercial population. And all of these are also represent an opportunity to do better with better care management. So here is one way to go about handling such a population. We will identify all members with a need for management of chronic and advanced illness, and for that matter, risk factors that are important to us. So all members get a health risk assessment, and we are very aggressive with the health risk assessment and have a greater than 80% completion rate for new members, and monthly predictive modeling. And in this monthly predictive modeling, we are looking for opportunity in addition to predicted high utilization. And this is in addition to screening of other things such as ER and acute admissions, but really the goal here is to catch them earlier than we might pick them up on other forms of screening, for example, acute admissions. Those that are identified are going to receive a comprehensive screen and a plan of management, and this is to identify all the clinical conditions and all the psychosocial barriers so that we can come up with a comprehensive plan of management. And we're currently enrolling more than 18% of all of our members, closer to 20% now, in care management, including new programs for home care management and institutionalized care management, and for that matter, a new program for collaborative care management with provider groups that I will be describing. The case managers are nurses predominantly, also social workers and behavioral health specialists and disease management specialists, all trained in geriatrics and all trained in care in change management, with specialized programs for advanced illness, which is a very important piece for Medicare, transitional care management, chronic illness, and other areas. Advanced illness or terminal illness is the former terminology, is a very important area for management in Medicare and represents perhaps the greatest opportunity for impact at the intersection of quality and cost. This represents about 25% or more of your total cost in a Medicare population. That is, the last year of life represents more than 25%, approaching 30% of your total cost. 80% of this is acute inpatient. And there is considerable opportunity for better management here because a good deal of the acute inpatient care provided here is not terribly productive, either from a clinical or a psychosocial perspective. And in fact, given an informed choice, the majority of individuals would not elect this type of care. The Robert Wood Johnson Foundation and others years ago surveyed populations, and given the question, given that you had a terminal illness and these are your choices, what would you elect? And 75 to 80% say they would elect hospice, and at the time they did the survey, the hospice election rate was running 10 to 20%, and it varies considerably by region. Now, it has increased considerably since then, but it is still there is still considerable opportunity here. We try and identify a population with advanced illness through various means, largely through predictive modeling, although increasingly we are looking for physicians to identify these with us. And in the last year for which we have complete data, 81% of the members engage in this program, and this is slightly less than 1% of our entire Medicare population elects hospice. This is associated with an 82% reduction in acute days, an 88% reduction in intensive care days, and a very high level of satisfaction. So the impact here is considerable. Now, I've been a medical director for a while, and as you might imagine, you don't often get to say 82%. And there are several reasons for this. One is, of course, you have a great program, goes without saying. But more important than that is that we're providing a service that is really almost desperately needed and often not provided, until late in the course of an illness, or perhaps too late or not at all. And that's the reason you can move the needle so much, because there's considerable opportunity. And I would say that in the Medicare population in particular, and not necessarily just limited to Medicare, this is our greatest opportunity for impact at the intersection of quality and cost. And we have, in fact, already demonstrated this, and some others have too, by the way. I could name them. And how do you do this? Well, I'm going to read one closing note. We've been at this for several years now. We have hundreds of communications, so I'm not trying to just pull out one isolated case, except this one is somewhat illustrative of what actually produces impact. So with your indulgence, I'm going to actually read this because it has more impact if you actually read it. So bear with me. Wife stated member passed away with hospice. Much emotional support given to spouse. She talked about what a wonderful life they had together, their children, all of the people's lives that he touched. They were married 49 years last Thursday, and each year he would give her a piece of jewelry. On Tuesday, when she walked into his room, he had a gift and card laying on his chest, a beautiful ring that he had their daughter purchase. She was happy, gave her to her on Tuesday. On Thursday, he was not alert. She states that through his business, he touched many people's lives, and they all somehow knew he was sick. He received many flowers, meals, fruits, cakes. She stated her lawn had become overgrown, and the landscaper came and cleaned up the entire property, planted over 50 mums, placed corn stalks and pumpkins all around. She said the hospice was wonderful, as well as everyone at the doctor's office and everyone here at Aetna. She tells all of her friends that when you're a part of Aetna, you have a lifeline. Encourage her to call case manager with any issues or concerns. Closed to case management. Now, the reason I read this to you is because you can feel in this note the depth of the connection between this case manager and this member's wife. And that is what makes a case management program work. It is not, if you see a program that appears not to have impact, you may find when you really look into it that the case managers get training on the web or with a manual, that they're reading scripts, that they're checking boxes of things that they have to say, but they're not actually making a connection. And it is this connection that really makes the program work, and not just for advanced illness. Yes, for advanced illness, but for chronic illness also. So when people ask, what is the secret sauce, what is the trick here, my answer is there is no secret. Everything you need to do this has been published, but it's not easy because selecting, hiring, training, and mentoring of case managers who can do this is hard and time-consuming, but it is otherwise worth the effort. So what is the impact? So now between chronic illness and advanced illness, which represents the bulk of our impact, at least the bulk of our short-term impact, what do we see? Well, compared to unmanaged Medicare, and this is risk-adjusted and geographic matched, we see 24% fewer ER visits. We see 31% fewer hospital acute days, and this is not associated with denials. And in particular, we see 39% fewer long hospital stays or stays greater than 15 days, which we attribute predominantly to compassionate care. Now, what we have published, most of what we've done and most of what we're discussing today in third-party and peer-reviewed journals, also also one in Time magazine, which is a bit of an exception here. And if you're interested in seeing any of these, we would be happy to send them to you if you'll send a message to us at the end of the presentation. There's no secret, or there's nothing proprietary about much of what we've done. So now let's take this on the road and basically move it into collaboration. And this is based on the assumption, which we firmly believe, that we have always had more issues, more goals, more ideals in confluent interests with our provider and physician partners than in conflict. And sometimes we tend to focus on the conflicting issues, but clearly if you will focus on the issues where we are we have confluent interests, we can probably accomplish more together than we can separately, and certainly than we can at odds with each other. So if we could take the care management capability that I just described and do it in collaboration with physician and provider groups, and meld what we do with what they do and focus ourselves on outcomes, on improving our quality in what we do, maybe we could accomplish some great things. And I think we've now been at this for nearly 5 years, and I think our experience in this area is considerable. So to us, what we call Medicare provider collaboration is similar to the ACOs, but we do have several years worth of results to discuss. So let's start with what is involved, and we start with incentives. Now, one of the points I'd like to make is incentives are important, but they are not sufficient. They do not create change in outcomes themselves. What you need is the infrastructure to do it. Physicians want to produce the best results possible for their patients already. You're not going to motivate them to do better. However, what you can do is you can help create the infrastructure, the resources, and the infrastructure for collaboration with you for us to work together to do better. Since there seems to be a great deal of interest in outcomes-based fee schedules or incentives, here is something that you might possibly have seen before, which we believe is the first outcomes-based fee schedule. It was implemented by Hammurabi in 1700 BC. And for those that are interested, an Awilam is a nobleman, a Mushkinim is a freeman, and a Wardam is a slave, and a shekel is about a month's wages for a free man. So here is a high upside and a high downside in terms of surgical outcomes. So the question is, did this produce better surgical outcomes or paraplegic surgeons? And the answer is actually we don't know, because as far as we know, Hammurabi didn't keep outcome statistics. But it does kind of illustrate the fact that outcomes-based fees are not an entirely new idea, and they have popped up in various times throughout history, including American history. So we think that this is the beginning of a process, not the end of a process, that it involves more than just incentives. So our collaboration model includes several things. One is we will pay more for managing and managing sicker patients. Now, basically, everyone has the sickest patients. So what we're looking at here is to identify the level of illness in your population by identifying the chronic illnesses, which is a process, as most of you probably know, which is also self-funding. But it does provide the ability to create additional infrastructure on care management. We also come up with mutually agreed upon quality metrics, and these include both process measures and outcomes measures that we agree on together, and we will measure together, and we will provide the data necessary to do this right. Plus, we collaborate on care management. We take the case management programs that I've just described, and we provide it to the provider group, preferably embedded in the provider group to work directly with them, at the very least dedicated to the provider group, so we can work together on care management. And the goals here that we're looking at are mutually agreeable goals for both of us, not just for one to achieve for the other. Our preferable route is for an embedded case manager to work directly with the physicians and the staff on site. And we're going to provide these for 1,000 or more Medicare members, and perhaps even for somewhat fewer if we believe that there's an opportunity for growth. Again, this case manager will work directly with the physicians and staff and create something better than we can achieve by ourselves. Now, we have about 75 of these now nationwide, and no two are quite identical. So we're going to have to customize what we do with what the medical group does. This might involve all the case management. It might involve sharing responsibility for case management or various other levels of collaboration. One of the points I could make is there are things that physicians can identify far better and far earlier than we can, and there are instructions that they can give to our case managers that will be very helpful in longitudinal care management that we can't. So there is tremendous opportunity once a case manager develops a trusting relationship with the physicians and the staff, and creates the feeling that she is their case manager rather than ours, even though she's our employee. We can see great things happen as a result of this. So one of the points I make is when you make inpatient rounds and you write a set of orders, you have a very high level of confidence that this will all get done. When you see a person in your office and you write some prescriptions and perhaps order some tests, a consult, a return in 6 weeks, and instructions of what to do at home, you don't have a very high level of confidence on 100% completion. That's actually been studied, and the 100% completion rate on an office visit is not terribly impressive. Now, we can't create the milieu of an inpatient facility, but if you have a case manager that has developed this type of relationship with you, and you can say, I just saw Mrs. Jones, and I need you to follow her up after she's gone. Make sure we get weights twice a week, and if it goes up more than half a kilogram, let me know. Make sure she fills this prescription, gets this consult done, and is back in 6 weeks. We can help with these things, and we will help with these things. And that's just a small piece of what we can do in terms of collaboration. So we'll bring all of the programs that I just described on site, and we will do it in collaboration. And as a result, we will be able to do better than we could do ourselves, or they can do themselves. So what do we see? Here are some quality metrics that we're looking to achieve. And these are just examples. They're not always the same for every group, but generally we're looking at a series of process metrics, which are the type of metrics that are reviewed by NQF. But we're also looking for at least one outcomes measure, and the ones we're most interested in are management of avoidable inpatient admissions, and that is we are looking for this collaboration to result in more avoidable admissions, less total admissions than we can accomplish ourselves, or for matter, that they can accomplish themselves. So we have about 75 physician groups to date. Some have been with us for years, and we're seeing some rather impressive results of about a 15% incremental reduction in acute admissions beyond what we can accomplish ourselves with our own case management program, again, exclusive of denials. And for some groups, we're seeing very dramatic impact. We're seeing reductions of acute utilization compared to unmanaged Medicare for their region of 50% or more. And I'm going to point out that we're talking about days or admissions that don't happen, which is not just a cost measure but a quality measure, as opposed to days that days that are denied. And we are seeing a high level of member and physician satisfaction with this program. So this is what we're seeing in terms of impact on acute admissions and acute days compared to our book of business, which already, as I indicated, shows a considerable impact. Here's one example that was published, and this is published in Health Affairs, and this is actually our very first, and we can send you a copy of this paper if you wish. This was our very first collaboration arrangement, so they've been with us for 4 years, so we actually have 3 years worth of data, and it's actually, this is 2010. Actually, I should be showing you 2011, which is even better. But this is Nova Intermed in Portland, Maine, and in this case, we are looking at their statistics compared to unmanaged Medicare for the Portland, Maine MSA. And we are seeing admissions reduction compared to this exclusive of denials. We don't normally deny an admission of 50% or greater. And we are seeing also considerable impact on subacute days, emergency room, and readmissions. In fact, the readmission rate in 2011 is below 10%. And mind you, it is customary to measure readmissions as a percentage of discharges. If you were to express this since the admissions themselves are down 50%, if you were to express readmissions as an absolute number, it would actually look twice as good as it appears when you express it as a percentage. So when all of the stars align well, when you have a group of committed physicians, particularly primary care physicians, that are really committed to making this work and to work with you, we can get we can get some very good, very dramatic results. So this collaboration changes the nature of the relationship with participating physicians. Dedicated or preferably embedded case managers enhance the collaborative care management process, the relationship with the physicians, and the impact. And we can demonstrate incremental impact, a high level of physician and member satisfaction, and this facilitates the transition to accountable care in general. And that is, some of these relationships can be broadened to beyond Medicare and beyond Aetna Medicare Advantage. In terms of chronic illness, where would we like to go? Where we and others are constantly pressured to produce relatively short-term impact, and we do in fact produce short-term impact. Our results are very good compared to unmanaged Medicare. We've been doing this. We established our care management program 10 years ago, and we've been doing these collaborative relationships for more than 4 years, and this is true of an increasing fraction of our total patients. But if you're going to manage chronic illness, which is perhaps one of your greatest opportunities, you really need to take a relatively long-term view of it. So I'm using diabetes here as an example, but truthfully, there are several such conditions, and you don't often see one condition in isolation, even diabetes. For one thing, diabetes causes other cardiovascular conditions. So diabetes will transcribe a course from metabolic syndrome to diabetes with tissue or organ involvement of various types to advanced illness. Now, the unmanaged progression here is just guidelines. This is a relatively rapid progression. This does not actually represent the mean, but it represents what might happen in a relatively poorly managed case or one which is not going very well. But basically, each stage of this progression will represent increased morbidity, increased clinical burden, and considerably increased cost. So metabolic syndrome might be about 1.35 times cost of mean. Diabetes may be 3 to 4 times mean. Diabetes with nephritis or neuropathy might be 8 or 10 times mean, and advanced illness is even greater. So this progression from one stage to another, it represents an increase in the disease burden and an increase in cost, and is to a considerable extent influenced by how well the case is managed. So if we could manage diabetes better and delay the progression of this disease, there is opportunity to improve quality and reduce cost both, as I would say again, the intersection of quality and cost. And collaborating with physician and provider groups to do so represents a great opportunity to meld our case management capability and medical groups, clinical capabilities to do as good a job as we can on longitudinal care management, and that is managing persons with chronic disease when they are not in your office. This means that we are not going to take a one-year view of it. We're always looking at one-year views of everything we do, but your great opportunity in diabetes and other conditions really suggests that what you really want to do is take a multi-year view, because there's going to be opportunities years in the future that if you know that this is still going to be your member, you can capture the value of multi-year engagement. Take another example. Take hip fracture due to osteoporosis. One thing you can do is try and do fall prevention, which can give you an immediate improvement in the rate of hip fractures. But if you're just doing fall prevention alone, the osteoporosis is still there and still getting worse if no one else is intervening in any way here. If you can identify a population with osteoporosis with bone density below the fracture threshold and work with the providers to try and get them to the provider and then get them on the appropriate medications, you can help increase the bone density and get this above the, quote, fracture threshold. But this is going to take several years. You're not going to see an impact on hip fractures, which are, by the way, clinically devastating. You're not going to see an impact in the short term, in less than a year. But you can see it in 3 years, for example, or more. Actually, it goes even further back than that, because if you really want to look at the process that started it, it was 30 years ago when she had a premenopausal hysterectomy. But we're not going to try and capture value going back 30 years. But if you will assume that a member is going to be with you for multiple years, that creates an opportunity to do longitudinal care management on chronic conditions. And if you assume they're going to stay with you, it gives you the opportunity to capture the value. So I'm going to transition to another opportunity, and that is transitional care. Now, this actually started before our collaboration program, but I'm going to try and tie the two together because there is opportunity to accomplish transitional care better, more thoroughly, when it's done in collaboration with our physician and provider partners. So I'm going to start with some of the work we did a few years ago with Dr. Naylor and her team at the University of Pennsylvania. So let's take one single case. A 76-year-old male, retired investment broker, active lifestyle, wife of 50 years. Wife is showing signs of cognitive changes. 3 children, living with families in other states. History of 7 chronic conditions under the care of 6 specialists. PCP is retired, family physician is retired. 9 prescribed medications. Health problems increasingly interfering with the lifestyle. She is admitted for a medical problem, and I'm not going to specify the medical problem right now because that's actually not critical. But it's time to go home. And 8 hours after when she goes home, she is given a sheet of instructions, including her medications and other instructions, and instructions for a follow-up visit in 2 weeks. 8 hours later at home, she can't read the discharge instructions, has questions about the medication, is weak and dizzy, unable to eat. She has scheduled for a physician for a follow-up visit 2 weeks later, but doesn't make it that 2 weeks. Before the 2 weeks are up, she is rehospitalized for a 4th time with an admitting diagnosis suggesting due to lack of adherence to prescribed therapy. And we see this sort of thing happen more often than we should. And it's a good deal of these readmissions that we see and there are a great number of them in Medicare, are related to some disconnect at some level. And there are multiple points of disconnect, but there may be something we can do to try and close some of these loops and alleviate some of these disconnects. So Dr. Naylor had already developed a transitional care program of her own, which she did with a Medicare population, and she was able to show significant impact, particularly on heart failure readmissions. At the time when we looked at this with her, our own heart failure readmission rate was already considerably below unmanaged Medicare. So we wanted to make sure that a transitional care program would provide incremental value as opposed to redundant value. And we were pretty convinced that there was, in fact, incremental value. We simply wanted to demonstrate it. So we took a population large enough to demonstrate what we were looking to accomplish in metropolitan Philadelphia, and we looked at discharges from a number of hospitals in Philadelphia, and we implemented a program in which trained transitional care management nurses would visit with them post-discharge, as soon as possible post-discharge, and multiple times if necessary. And this is the population that we're looking at, mean age of 76 with a mean of 7 chronic conditions, 8 medications, and nurses addressed 32 different types of problems with 173 discharge patients. We're focused on multiple conditions and therapies, functional deficits, emotional problems, poor general health behavior, poor subjective health rating, lack of local support, many cases cognitive impairment, language literacy, and cultural difficulties, all relating to care completion and successful discharge. This results in a high rate of medical errors and other acute clinical events, serious unmet needs, poor satisfaction, and ultimately acute readmissions. So we're targeting interventions aimed at promoting effective handoffs, and we're looking at comprehensive interventions designed to address the root cause of avoidable acute care use. So a population at discharge is screened based on a previous history of readmissions or care completion difficulties and particular diagnoses associated with readmissions. They are engaged, both them and caregivers are engaged. We are looked to manage the symptoms, and we linked the transitional care nurses developed through the University of Pennsylvania to our own case management capability to work to collaborate, to work together, and assure continuity of care, coordination of care, and that the relationship with us and with the physicians managing the case are maintained. So we maintain continuous communication between the physician, our case manager, and the transitional care nurse to try and head off problems before they become readmissions. So we linked the transitional care program to our geriatric case management program. We partnered with a home care agency, and we targeted 200 members in metropolitan Philadelphia, and we clearly defined the roles and workflow processes. And these are our results. We looked at the self-reported health status, the symptom status, depression, functional status, and quality of life. And we are seeing improvements. We're seeing a high satisfaction with the program, and we're seeing a high satisfaction by the physician with the nurse's involvement in the member's care. And we are seeing reductions in hospitalizations 3 months post-intervention. So if you look at 0 to 3 months, and we're not looking at just 30 days here, but if you're looking at 0 to 3 months, we see a significant reduction in readmission from this program alone. And this program, by the way, does not include a hospital visit. This is just post-hospital visit. It does not persist much beyond 3 months. After 3 months, we're looking at readmission rates that are not statistically different from the baseline. But we're getting a pretty good effect on 0 to 3 month readmissions. So again, the hospital component of transitional care was not implemented in this particular example. But we do see a very good impact at 0 to 3 months on readmissions, on skilled nursing facility use, and on total cost. So it was based on this program and these results that we decided to begin building this type of program wherever we have the capability, the member concentration to make this possible. And we're also doing it in collaboration with our provider collaboration partners to try and create a seamless care management process between us and our physician collaboration partners so that we could show greater impact on avoidable admissions in general and readmissions in particular. So that's where we're looking to where we are, and that's where we're looking to go. I think what we're looking to do in the future is expand on what we've seen. We would like to see a larger portion of our members in collaboration relationships. We would like more collaboration partners and more members through these relationships. We would like to deepen our level of involvement with these groups, more embedded case managers, more programs in collaboration with them, such as transitional care, and more engagement long-term with members of chronic illness, and better identification through collaboration with our physician partners of members with advanced illness. So I believe that we've come a long way here, but I still think that there is still a long way to go to get where we want, and that is, again, demonstrated impact at the intersection of quality and cost. Thank you very much. I could take some questions now.
Yes, thank you. For our attendees, please do, if you have questions, go ahead and enter them in the chat and press send. And over to the left, we already have some.
Right, I see some already. So I'll start with this one. What type of collaboration partners do you look for? We have a wide variety of collaboration partners. One thing, we're certainly looking for a good number of Medicare Advantage members with that group of physicians. We're really looking for 1,000. We have many groups with less than 1,000, but most of these in which we're hoping to get to 1,000. We're looking for a good, strong primary care base and a good level of commitment by the physicians to working with us, and we hope that we can help build that type of commitment. That said, we have partners that are primary care groups, that are multi-specialty groups, that are integrated healthcare systems, and some that are pods, that are collections of physicians in a community. It's not just the organizational structure that is necessarily the most important piece, but it is important that we get really commitment to the concept by the physicians. How long is the care transition intervention with the patient? Is there a handoff to the case manager? And it's not necessarily just the embedded case manager, by the way. It's the case management program in general. We're usually talking about two or occasionally 3 home visits over the course of the first few weeks, occasionally longer. And basically, this goes as long as necessary, and hopefully there will be follow-up after that by our case manager. Let me see. Of your members today, what % are managed in this innovative manner? Well, if you're talking about our care management program in general, as opposed to the collaboration program, we engage approximately just short of 20% of our entire membership in dedicated Medicare care management, about 1% in advanced illness management. If you're talking about what a percentage of our membership is in collaboration arrangements, it's less than we would like. We would like to see more. It's just short of 60,000 right now. We're looking to have more than 50% of our individual members in these type of arrangements within the next year, and we're very aggressively building to that level. Oops, this thing keeps moving. The transitional care nurses visit the member who they are collaborating with, PCP or home-based. Okay, the transitional care nurses visit the member at home after discharge, and for that matter, as soon after discharge as possible. And we now have these programs in several locations, and we're working to build more of them. Do you have any programs for post-acute care providers, facilities, to assist in reducing acute care hospital readmissions? Yes, we do. We'll take some time to discuss this. I think I'd like to answer that one offline. I think that's that one. That the answer to that would be rather involved. What does your predictive model include? Okay, the predictive model is actually proprietary, but it identifies a population with 1, predicted to be high utilization, and 2, predicted to have opportunity. So we're looking for the presence of chronic illnesses. We are looking particularly for advanced illness for basically the likelihood to die within a year as an additional flag. We are looking for a history of ER and or hospital utilization. We are looking for particular medications associated with opportunities. We are looking for certain trigger conditions, certain trigger events, certain trigger medications. We are also looking for the absence of certain things that are normally present, actionable gaps in care. We're looking at drug interactions, and conceivably these are drugs that are prescribed by 2 physicians who are not even aware of each other. We're looking for testing that is, or medications that is missing for a particular situations. So, for example, someone with heart failure that's not on a beta blocker, someone, a female who is older than 65 with no record of having had a bone density. So we're looking at a wide variety of different things in which there may be opportunity. Do you use Aetna staff for this, or do you contract with other providers? We contract with physicians, providers. Our medical directors do not actually own medical delivery systems. However, the case managers, including the embedded case managers, are Aetna employees. We hire them, we train them, and we mentor them. So that the case management program is ours. What is the ratio of members managed to one case manager? We're looking for this in Medicare. We're looking for this to be about 1 to 1,000. I'm going to. I will answer the question about community pharmacists. I will get back to you with a separate answer on that one. The person who asked that question. That's the end of the questions I have on the chat box.
Okay, thank you. Quite a few questions, flurry at the end there. A couple more just came in. We do have some more time. If either of those look interesting to you, Dr. Krakauer, at the very end of the
Univita question mark. Univita has been contracted to work with us for home case management and transitional care in Texas for Medicare Advantage for Texas. We just got started with them in January. We're very impressed with Univita. We're very impressed with their staff and with Dr. Mock and what they've done. I think we're looking at the engagement. It's coming through. We just started in January. It's a little bit too early to say to report impact, but we're quite optimistic about the program in Texas right now. From the post-acute, I'll contact you by email. How can one case manager work with 1,000 patients? They don't. They work with the population that is identified for impact by the means that I have discussed. They carry a caseload of approximately 55. Do you use the AIM protocol for advanced illness? We use a program and process that is in many ways similar to the AIM. We developed it ourselves probably about 5 or 6 years, 6 or 7 years ago. So we probably were developing it at about the same time that Brad Stewart was developing his. And there are certainly many similarities, and to a large extent, we're doing very similar things. What is the social work role in your program? A number of our case managers are in fact social workers, and they are very valuable and they're very important to us. We identify psychosocial issues, and when appropriate, we have the social worker case manager engage and help manage these. And there are many cases in which you can't get to the clinical issues until you've addressed and managed the social issues first. So the social work case managers are a very valuable component of your team. And that looks like that's that. Now we are again, no more questions in the chat box.
All right. It looks like we are out of questions. Oh, they just keep coming in. As long as you're comfortable answering them, I guess we can.
On the results slide, how do you explain the impact on SNF reductions? Two. One is reducing acute admissions / discharges will reduce SNF admissions post-discharge. And number two, we also look at SNF length of stay in the usual manner. Okay. Thank you. Okay, we have a question about a copy of the slide deck.
Yes, there's actually a copy to the PDF for the slides that came into your email that was that had the connection information. So if you look in there, you can find it. I'll give that again real quickly. That's healthwebsummit.com/Aetna031413.pdf. Again, that's healthwebsummit.com and then /Aetna031413.pdf. So thank you very much. And I'd like to thank Dr. Kreger for an excellent condensed presentation and a lot of great questions and answers. So I'd like to thank our session attendees for joining us and providing those questions. We'll be sending a follow-up feedback form immediately following the conclusion of this session. We'd appreciate it if you could take a few minutes to share any thoughts about today's session. Also, you can join our LinkedIn group via the healthwebsummit.com website, where you can continue this discussion, post questions, and suggest topics for future events. And with that, we conclude our event. Thank you very much.